Julie's come in today to join us here, and we're here talking about a hot topic in this field, which is about screening. And a lot of people, a lot of centres are interested in knowing, should they adopt a screening program, or is it too much of a burden on either staff or patients? What I want to do today, if it's okay, is get your perspective as a recent patient who's been through the system on whether screening for distress, for anxiety, for depression is really worthwhile in your opinion. We've had a look through a few tools that are used in clinical practice, some of which are local, some are national, some used elsewhere. A good place to start is to just think about whether distress, anxiety, depression are picked up in the normal routine if we don't do anything. What's your opinion on that? Are we picking up on an adequate number of patients who are coming in? Is everyone detected, basically?
From personal experience and speaking to others who have experienced cancer, I would say that in the main, absolutely not. I think that people are so busy, clinicians, dealing with the cancer treatments physically, the chemotherapy, the radiotherapy, any other associated issues and treatments they have to bring in, and even sort of attached teams like your radiotherapy assistants and chemo assistants. They are busy processing patient treatments and cannot tune in to patients' emotional and mental feelings at that time. I personally experienced a meltdown in a very public place, which caused me even more distress than the problems I was dealing with. By the time I got to my radiotherapy stage of my treatment. So I'd already been on the cancer journey a good 6 months plus, and nothing had been picked up.
Does that imply that things are picked up on occasion, but it's often in the very late or severe stages? In other words, only when it's unavoidable do the clinicians who are otherwise busy actually attend to an emotional issue?
I think that from my own point of view, and as I say, we're speaking to various people, it was only when they got to that point where they couldn't physically enter the building to go for their next treatment, the relatives were struggling to manage that situation and didn't know how to help them. They were perhaps going through their own worry and distress as well. And the fact that I physically was undergoing an actual treatment when I went into a meltdown. I just couldn't speak, and my distress was very obvious in a physical sense. But before that, obviously, it may not have been so noticeable, but it was still there and it was increasing.
Now, the literature from studies worldwide back up what you say, that many patients are not detected in a timely way.
Yes.
And there's a study just out this week, it was on the radio, wasn't it? We were listening to it earlier.
Yes.
About depression and cancer, looking across 21,000 screens in Scotland, finding that 74% were not attended to, their depression was not attended to in a timely way in an oncology setting, which is a concern. So I guess screening has an option, it's available. Just because something's available, though, doesn't mean to say it's actually used. It doesn't mean to say it will actually work. Sometimes there's a doubt about which tool to use. Before we go into the tools, just in principle, the basic tenet of screening is that a cancer clinician who's otherwise busy could apply a relatively simple method to give them a result which would be a key indicator that the person's struggling. Do you think that that would be a worthwhile thing to do? And if so, when should it be done? How should it be done? I know that's complex, but what's your opinion on that?
I think it is difficult. It depends on the type of clinician you've got. It depends on possibly the type of patients you've got. Most people aren't necessarily going to have a reaction against the fear and anxiety and depression that can come along with a cancer diagnosis. Most people would probably imagine that will happen at the first visit, when you're actually told at the time of your diagnosis. But I found personally, and I know others have, that it's not necessarily the case. You get a bit more fight in you that, you know, you're going to fight this thing just as you would cure something, and everybody starts along that road thinking, well, this is something to be dealt with. It's only when you're battling along that road and you actually find that it's not so easy to deal with, that it can't necessarily be dealt with, and maybe depression and anxiety are creeping up behind you, and sometimes you're not even aware of it. So possibly, you know, at visit 2 or 3, before you see the clinician, so that you can express some emotional views before you start discussing and going through the physical treatments.
Yeah, now that's very interesting, because although visit 1, the kind of diagnostic occasion, is considered to be like the key opportunity to screen, nearly everyone is going to be distressed and upset and anxious on that occasion.
Yeah.
Often later, the input is perhaps less intense. You know, for example, after the acute treatment's finished, after the discharge home, after the clinicians stop watching you so closely, even then, it's quite likely that distress, anxiety, anger, different emotions can be problematic. Perhaps we should be looking in the longer term as well as in the short term. The question there in my mind, though, is how would we do it? Because you can pretty much see a system working in the hospital. We'll talk about that in a second with these tools. But what would the system look like in order to spot people who are back at home on their own, not necessarily coming for hospital appointments? Any suggestions on that?
As I say, if you've touched base and picked up that there's a problem in the clinic or on a ward, then obviously that's easy to deal with. I think that resource and importance cannot be stressed highly enough, to be put across into those areas of support emotionally and mentally. So yeah, actually, when treatments are finished, I was personally coming to the end of my cancer journey when I went into meltdown. I know others that have. Then again, by the same token, I've spoken to other patients who had a meltdown at the beginning of their treatment. Everyone is different. Therefore, there's got to be a variable. There's got to be a flexible system whereby patients can be monitored, in my opinion, and given the support that they need. So that teamwork, that emotional attachment to oncology, like the psycho-oncology system, has got to be in place, and I think people have got to recognise there's a service there that is essential, and it's got to be monitored, and there's got to be two-way communication all the way through, as the patient may need more input or less as the journey goes on. What
you're saying is quite right, that we need to tie the assessment process, which I'm talking about today as screening, with the quality of care that's received as a whole, the communication process, and also continuity, so that things are attended to and followed up rather than left.
That's right. And you don't want to feel abandoned once you have attached to a service that's supporting you mentally and emotionally, which is getting you through that battle that you've got. And as I say, when you haven't, the issues that you're dealing with after cancer, it's important that that relationship is maintained. That treatment plan is still ongoing, I think.
Yeah,
definitely.
So let's come on to a different question. It's related, but it's about the tools themselves. We've been looking at some of the tools this morning, and as you know, several of these are used in clinical practice, and you were personally comparing different types. And just for the viewer's perspective, we've looked at the HADS, Hospital Anxiety Scale. We've looked at the PHQ-9, that's for depression. We've looked at the GAD-7. Now those are they all share a kind of slightly old-fashioned question and answer type of format. We've also looked at some more modern ones, like the visual analog scale, our own emotion thermometer, which includes the distress thermometer. Without influencing you, what's your opinion on the formatting and acceptability to patients if they were presented with any of these tools?
Well, I think that obviously they've got to be easy to understand. I think you've got to realise that you're dealing with all ages, genders, different backgrounds, people who may not be able to see easily or understand quickly the written form as opposed to visual. So for me, some of the older, more traditional, this DSM and this PHQ-9, whilst they've got the relevant questions in about moods and anxiety and scales, they just look a bit too technical for me, and I think that might overwhelm a patient that's already dealing with things mentally and emotionally. To me, the one I think that performs the best is actually this much simpler format, which is the emotional thermometers one. I like the fact that's very easy to understand. It's categorised very clearly, the different things. And a good thing that they've brought in here is the fact that not only am I exhibiting these problems, am I needing help for it? Because some people may go into close down and say, I don't need help because I'm trying to cope. They may not have vocalised that, but in the written form, they might read that and think, well, yeah, actually, I think, you know, although I can manage by myself, I'll put it at the top of the scale to say that's bordering on the fact that I'm now looking to realise I need help. Which is quite a big thing, I think, for people already going through that. The other things I particularly liked about the format of this was that you've got all the emotional thermometers here about what you're dealing with. Underneath, you've got some really good questions here, laid out quite clearly. Things that may not be covered by somebody having to look at those older, more traditional things. You know, little bits at the bottom where if an item is not covered, such as, you know, loss of role or about appearance or anger or worrying about the cancer, if there's another area that's worrying them, and it can be something that as clinicians or even as psycho related specialties we don't think of, the patient who's experiencing them will certainly think of. That's something additional, you know, that helps people to help the patient. So I like that. And obviously at the bottom here, I think it's quite good that it gives a box here, the action taken. In other words, it sort of prompts the clinician to say that it's all right hearing about these things. What are we actually going to physically do to to help the patient? It gives them a prompt to say, here's the situation, what am I going to do? And obviously it's a useful document that stays in the patient's notes and things, I would imagine, from a clinical point of view, that you can see exactly what things are needed, because sometimes it's probably quite hard as a clinician to keep note of all of the different medical stuff that's going on. It's all written down, you know, you're seeing a lot of patients. This might actually point to some glaring big stuff that is not actually obvious looking at the patient. So it brings quite a lot out, I think, there, and it covers all areas like family issues. It even covers things that, you know, immediately when people think about cancer, and being a patient myself and having a cancer that was hormonally related, things like, you know, sexual intimacy issues, hormonal issues that can, you know, affect patients quite a lot. So yeah, that's, to me, this is the one that I think is easy for the patient, it's clearer, and it's not so scary to fill in.
Can I explain for the viewer? You were talking there about the embedded version, which is actually augmented with the clinician. So the thermometers are the starting place. The second bit, which you clearly explained there, is about the needs or problem checklist. Basically about unmet needs. What's the cause of the problem? What's the cause of distress? What's the cause of anxiety? What's the cause of depression? And then the third section on our screener, which we trialed locally, is the action taken by the clinician, where we monitor whether they respond to unmet needs. As you know, we've trialed this locally, not just completed satisfaction forms, but actually trialed whether it was successful or not successful. One thing I want to run by you is roughly a third of clinicians when we trialed it, said, oh, it's really working for me. It's helping my clinical practice. It's actually an aid to communication. A third or so said, yeah, there were some areas where it helped, but I'm not too sure, but I'm definitely willing to run with it. But that left a third who said, well, actually, no, I don't really see it as helping that much, or it's a burden. You know, I'm already busy. Why are you giving me like these extra responsibilities? What would your comment be on that? That particularly the third who don't particularly want to use it. Can you understand where they're coming from?
I can, because obviously there are 3 pieces of paper here for them to look at, albeit in a much easier format than some of the variances I've seen. My take on that is yes, but if this was something clinical, purely clinical, like this drug, how did it affect you? How did you feel? Was it going in an IV site well? How did you feel afterwards? They wouldn't think twice about, from a clinical point of view, completing that, spending a bit of time with their patient or some of their team that was attached to the specialty, going through that and then put it in the patient's notes, and it forms part of the patient's pathway. For me, this has got as much relevance, if not more so, for that patient pathway, because it's about the emotional, psychological health of that patient, which in the main will have been prompted by cancer, the diagnosis, the treatments going on around it, how things are affecting them in the family, their own personal views, fears, you know, and worries around that. So it's an interesting take that some clinicians will feel that way, but I think from the patient's point of view, it can't be stressed highly enough, having been one of those patients, of which there are thousands of us, how important it is that our social and emotional, mental well-being is as important along the journey as the medical one.
One of the things that's always interested me is whether screening, being asked to answer these kind of questions, could be perceived as a burden to some patients. Remember that the question about when to screen and how often. If you were quite upset at the time you just received difficult news,
yes,
would in your opinion patients still be amenable to completing what could be seen as a kind of formulaic thing, or would it be better to wait until another opportunity, or alternatively use a different method which was basically applied by the clinician, so it was more personal? What's your view about that?
I think you've got a good point there, because people who are told that diagnosis tend to go into, well, from a personal point of view, and speaking with a few other patients, you know, they go into denial or shutdown or anger or shock, and basically it takes you all your time to look round the room and believe that what you're being told is actually referring to you and not someone over your shoulder. And I think different patients will take that in different ways, and because of that I think it probably is a wiser thing not to introduce this at the first treatment or session where the patient's given the diagnosis, because I think with anything like this that's such a big thing in someone's life, and it is a shock, even though sometimes you may have an inkling that something is going along that road until you're actually told that it's a cancer situation. I think that you need that time to assimilate things mentally and emotionally. You need that time, and that is the time when actually all those, but what if, oh, you know, this may happen, that may happen, all those nighttime moments, as I call them, where you're on your own with your own thoughts, where the major anxiety and perhaps depression issues start to build up, that is the time when really you can start analysing how you feel in various areas. And then you've got insight as well, remember, into what treatments you're having, how physically they're going to affect you, how that's going to change your physical appearance, how you're going to feel physically, emotionally around it, mentally, how you're going to cope. So a lot of the information that is required for people to make a supportive decision for your care, emotionally and mentally, doesn't actually strike the patient until, I would say, you know, a good month perhaps or so along the cancer journey, when different things are happening and you have different expectations, and sometimes they're not met, sometimes it's better than you thought, sometimes it's worse. That's the time really, I think, when this support and the questioning around what support's required and identifying it, more importantly, before it gets to a bad stage, really comes into its own.
Along similar lines, if screening was done later, perhaps after discharge, there's some new methods that have been suggested, basically high-tech methods such as screening online, self-assessment, that kind of thing. Sounds a bit like taxation here. But basically my question for you is, do you think these methods could work? Can a web-based screener, can a self-assessment screener, could an app, could it serve the same purpose? I can see it outreaching to many, many more people. But in your opinion, would patients be willing and honest in that situation? Because they might not know what happens next. Do you know what I mean? Depending on the result, something might be triggered that they're not too sure about.
Yeah, I think you're right. I think it works well at the top end of the scale in positivity, in the fact it's easily accessible, it could be private, it can be something that only the patient, no one in their family or their friends, it's personal to them. They're not going to a hospital and identifying the fact they're visiting a hospital and people are aware of that in the family. They can do that privately, like a video diary sort of thing. And so it can be exactly as they feel at that moment in time, and as raw as they feel and as honest as they feel at that moment in time. So in that way it would be a good thing. In a negative sense, I think that possibly people would feel that's too clinical, too, you know, false. It doesn't feel like an empathy thing. I don't know if it has to be that way to work. For me personally, I don't think that would have worked. I think that some people as well would feel that if they're in the hospital cycle, if they're undergoing that process, that they feel that the psychological treatments and input are as important as a medical one, and therefore they should sit side by side in that environment and at those visits. Others may feel differently. I think that will depend on the personality of the patient as well, to be honest.
Julie, thanks for coming in to discuss screening. I've got a closing question for you, which is just, in your opinion, how much of a priority would you rate the implementation and uptake of screening across different units on a scale of 0 to 10? So 0 is not really priority at all, just stay as we are. 10 is it's the top priority across, you know, anything you can see. What's your opinion on that scale? I'm not influencing you. I haven't asked you that before.
No.
So what would you say now on that 0 to 10 scale?
Well, in all honesty, I would say that because I went through that process, I experienced not only that pain of the cancer journey, but it was compounded and made worse by the mental emotional distress around it and the embarrassment of having to get to a stage of going in a public place into a meltdown before I got treatment come in. I would say 10, definitely. And I think that the more people I've spoken to of all different ages, genders, types of cancers, prognoses, you know, they feel exactly the same, that it is a massive part of a patient's cancer treatment. It is absolutely essential. And I think the screening is a really, really good innovation to bring in on that journey. As much, you know, at the beginning, obviously, as you can.
Thanks very much. Thanks for your insights. That's been really, really valuable.
Thank you.